Hello there. Once again, I'm Tony Meekum. Let's start getting into diagnosis. So this is the first of lectures getting into diagnosing lesions within the jaws. I have this course split up by differential diagnoses. So if you see some well-defined unilocular lesion within the jaws, whether the maxilla or mandible, you can start with this lecture. Download this PowerPoint if you haven't already. And hopefully this can guide you through a differential diagnosis to have an idea of where to start. And so I don't have it split out by location because most of these occur most commonly in the posterior mandible. And all of these can occur anywhere, but of these lesions, for the most part, they're going to be most common in the posterior mandible anyway. These are my references. Refer to your texts. I refer a lot to White and Farrow. Some of the images in this PowerPoint are from the oral pathology book by Chi and Neville. So here's our outline. We've got 9 different lesions. The good news is we already covered 4 of them in the previous lecture, the common periodontal lesions lecture. So we're only going over 6 lesions in this lecture. First, I want to talk about the general features of cysts, and I did this as well in the previous lecture when I was talking about periapical cyst. We talked about the definition of a cyst. It is a fluid-filled cavity that's lined by epithelium, surrounded by some connective tissue wall. The features, general features of a cyst is that it will cause swelling. Usually they lack pain unless they're secondarily infected, which anything can become secondarily infected if it communicates with the oral cavity. So I show this water balloon here because this really is going to be similar to how a cyst can look, especially if a cyst starts to align a very thick cortical border. I showed one example of a cyst that's on the inferior floor of the mandible, and then it kind of curves around that border of the mandible. Over time, it can enlarge, it can expand, and it can expand cortices outward. But if you see it really sac-like, really water balloon-like, that's a very cystic type shape. The periphery is typically going to be well-defined and corticated. Round, oval, or we'll call this water balloon shape hydraulic. In some cases, they can appear scalloped, especially against the roots of mandibular teeth. And we'll talk about 2 specific cysts in this lecture that cause or tend to cause that scalloping appearance. They're typically radiolucent, right? As you expect from a fluid-filled sac, it's going to be radiolucent. There's not calcification inside. There are rare exceptions to that. A long-standing any type of cyst may form dystrophic calcifications, and there are certain cysts that are known to cause calcifications, and I cover those in a different lecture where you have radiolucencies with internal calcifications. Sometimes cysts can have a multilocular appearance, meaning it looks like little small locules, think of like soap bubbles, all together in one lesion. So we'll call that multilocular. And always remember to describe the effect on other structures. That's something that people forget a lot. Where there's displacing structures, cysts tend to do that. So can benign tumors, anything that's slow growing. As it grows adjacent to something, it can tend to displace them. In rare cases, it can resorb roots. I would associate that more with benign tumor type things, but anything can, OKC, Ameloblastoma, even Dentigerous cyst, they can resorb roots. And in this lecture, we are talking about some benign tumors. So just because I'm talking about the general features of cysts right now, don't think that all of these are cysts, but I'm talking about well-defined unilocular radiolucencies, which tend to have the appearance of a cyst. So what is the most common radiographic appearance? Hopefully you could describe that. Well-defined corticated border, right? If something's very slow growing, a cortex is able to be maintained around the lesion as it grows, so it has a corticated border. Very round, very fluid-like. You like my background, by the way. Sometimes I'm astounded by my own creativity. Help you remember this is a cyst lecture or a well-defined unilocular lecture. We have this bubble-like background. We've shown you this in the common periodontal lectures, or common periodontal lesions lecture. This very sac-like, cyst-like lesion. This is a periapical cyst, and another one just in a coronal view. We showed you this one as well, so we talked about that. Very round, very well defined and corticated. Looking at the occlusal radiograph, it maintains this cortex around it as the periosteum is able to lay down more calcification. So that tells you that it's slow growing. And yeah, everything about this is just cystic and slow growing, very benign in appearance. Same with this one, if you remember this one from the last lecture. This is not an OKC, although you would probably have it on the differential. This was a previous periapical cyst, so we'll call this a residual cyst. But everything about the shape, the form of it, the borders, very cyst-like. All right, let's start with the dentigerous cyst, also called a follicular cyst because it's a cyst that occurs within the follicle of a developing tooth. So fluid accumulates within this follicle between the epithelium and crown of the tooth, and that's what forms a dentigerous cyst. Clinical features are all going to be typical of a cyst. But this is the key right here, above and around the crown of an uninterrupted tooth. The other key is where it attaches. Because it's a follicular cyst and the follicle tends to attach at the CEJ, the follicular cyst should attach at the CEJ of a tooth. So look for that when you're trying to distinguish a dentigerous cyst, but you may have other things on the differential. But if it attaches lower or apical to where the CEJ is, I might think something like an OKC or Ameloblastoma before dentigerous cyst. As far as cysts go, a dentigerous cyst has a propensity to resorb roots of teeth. You know, cysts are just sac of fluid. They don't have inherent growth potential, and they tend not to resorb things, but dentigerous cyst is maybe an exception to that rule. So here are some examples. A follicular cyst, you see it attaches at or just below the CEJ here. This one, it attaches a little bit higher, but very easy to imagine that this is a cystic type lesion arising from within the follicle of this tooth. Is it resorbing the roots of this tooth, or is it just overlapping? You can see the root still intact. So this is just overlapping to the buccal or lingual of where that root is. What do the borders look like? Would you describe those as well-defined? Hopefully, because it is well-defined. Corticated, you see a thin cortex around it. Maybe the cortex is eroded up here, the alveolar crest. It's eaten through the alveolar crest. But for the most part, it has a well-defined corticated border, so you're thinking either a cystic or benign tumor type lesion. In image B here, has this one resorbed the root of the tooth? Yeah, you don't see that root at all. And notice the pattern of resorption. It really follows the line of that cyst, and it maintains that well-defined shape, pretty much in line with the periphery of your dentigerous cyst. That's a very benign pattern of erosion. When we get to malignancies, we'll show the difference with the malignant type pattern of erosion of roots of teeth. So either malignancy or benign things can erode teeth. Dentigerous cyst, as far as cyst goes, as I said, is more likely to, but not necessarily. It doesn't always resorb the roots of teeth. Here's another example, a little bit grainy, but where does the border of this attach? Just below the CEJ. Just apical to the CEJ of that tooth, and that's pretty normal. So either at or just apical to the CEJ, and this is a very typical dentigerous cyst. We see a little communication through the alveolar crest, a little, what we would call that a gubernaculum dentis, where there's a little path for an erupting tooth that guides it into the alveolar crest where it erupts. All right. Hopefully see this here. It stands out pretty readily. How would you describe the borders? Hopefully you recognize these well-defined corticated borders by now. The mesial surface, you don't really see it attached at the CEJ. Maybe there's a little follicular space here. But the distal definitely attaches just below the CEJ, and so this is most likely a dentigerous cyst. Is it displacing structures? Likely. The inferior alveolar canal likely is being pressed down here. I'd rather see a three-dimensional image and really see what's going on with the canal there. But yeah, displacing structures, well-defined corticated border, very cyst-like, growing into the ramus in this case. Another example where at the distal it attaches at or near the CEJ, and the mesial just looks like a normal follicular space around the crown of the tooth, expanding a little bit into the ramus as well. All right, in this one you may just notice a tooth up here. Which tooth is that? It looks like it's a canine. And we have the deciduous canine retained here. The succedaneous canine is displaced posteriorly and superiorly into the maxillary sinus. What's likely to do that? Well, something that arises around the crown of that tooth, a dentigerous cyst. So even though I don't see borders of the cyst attaching at the CEJ of the tooth, that's a likely candidate for what could have caused this to become impacted as it is and be displaced into the sinus. Here we see it in three-dimensional view, a coronal view. Borders are very well defined and intact. In some cases, they're definitely corticated. So you're thinking, yeah, well-defined corticated cyst-like lesion or benign tumor. In some cases in here, it's resorbed into the nasal cavity just from pressure resorption. You see that in the axial slice as well. You don't see corticated borders all around it, but in some areas there are definitely corticated borders. And so you're going to have corticated type lesions first on your differential when you see that. And in fact, in the axial slice right here, you see where it attaches to the CEJ. So that's a strong indicator, even though you didn't see it in the panoramic, an indicator that this is a dentigerous cyst. Plenty of examples of these. Right, they're one of the more common type of odontogenic lesions that you're going to see. So these are taken several years apart. A cyst-like lesion around the crown of this tooth. I don't necessarily see it attached to the CEJ, but easy to imagine that this is a follicular cyst developing from within the condyle and displacing the molar superiorly. Several years later, it's even further displaced superiorly. Probably would have been better for this patient to have excised it at that point. Even larger lesions here. This one is displacing this third molar, doesn't even have the roots developed, it's displacing way down into the inferior border of the mandibular body, almost into the angle of the mandible. Well-defined corticated borders extending back here into the ramus. A corticated border being displaced superiorly here. The mandibular ramus doesn't usually look like this on a second molar. Corticated borders out here. Inferior alveolar canal. You can see this dark line, radiolucent line going through here. Similar lesion here. A developing first molar in this case. You can see the premolars developing here. So young patient. Second molar is just developing, just starting to calcify the cusps. And the second molar is being displaced way up into the ramus, almost into the coronoid notch there. Little expansion, both superior and inferior. Everywhere you see the borders, though, they are well-defined and corticated. All right, this is one where radiographic diagnosis can help a lot because the histopathic appearance is not very specific. You just have general, usually a thin epithelial lining. And so that attachment of the cyst to the CEJ is important for coming up with your final diagnosis. Sometimes we don't realize how important the radiographic diagnosis is toward leading the histological diagnosis. It is common to have hyperplastic dental follicles, and unless it's beyond, say, 5 millimeters from the crown of a tooth, you may not have dentigerous cyst as the most likely candidate because hyperplastic follicles can occur with some regularity. OKC, we'll talk about those and Ameloblastoma next and how to differentiate them. AOT, or adenomatoid odontogenic tumor, we'll talk about with our calcifying lecture. And then we've already talked about radicular cyst, and history is going to play a big part of that. All right, management is going to be surgical removal, as it will be for most of these cysts and benign tumors. If it's a large cyst, they may be marsupialized, which means, and this seems to have gone out of vogue in recent years. I appreciate images I've seen of this when large cysts have been marsupialized, which means the surgeon cuts into it and leaves a little drain and allows that cyst to depressurize. The fluid drains out. You leave a little tube that drains out the internal component of the cyst, and the bone will heal around that cyst over time. And I think one of the reasons this is out of style is because it requires very strict adherence, keeping everything clean by the patient, and sometimes they're not well handled by the patient. But I've seen great examples of shrinking cysts by marsupialization before removal, and that makes this surgery a lot more simple. Synonym for a dentigerous cyst. Where does it come from? It comes from a follicle. So follicular cyst was the synonym. And what's the best way to differentiate from other type of cysts? Think of where it attaches on the tooth. Yeah, it comes from the crown, and if it attaches right at or just below the CEJ, it's very likely to be a dentigerous. And as a radiologist, I don't like to deal a lot with soft tissue lesions. I only see in black and white. But this is an important one. This is kind of the soft tissue counterpart of a dentigerous cyst. Of an erupting tooth, you have that follicle. If it's filled with more fluid, you might see this translucent or bluish swelling right over a cyst that's going to erupt. And what's the treatment for this? These don't necessarily require treatment. As the tooth erupts, the cyst will kind of break out into the oral cavity and drain, and it can be fine. Or you could do a small incision and drain it yourself. That could, in theory, help with eruption of the tooth. All right, OKC. This is one of the common board questions because it is a somewhat common tumor, and it's gone back and forth as whether the World Health Organization categorizes this as a tumor or a cyst. At the moment, it is back to being a cyst, so odontogenic keratocyst. At one point, it was KOT, keratocystic odontogenic tumor. So that may be used as a synonym for it, or if you look at old literature, they may refer to KOT. Just know that they're talking about the same thing, this OKC. These other terms have gone kind of out of style as well. Globulomaxillary cyst is something that they used to describe as an anterior maxillary cyst, usually around the canine or lateral incisor. And they found that some of those are OKCs, some were lateral periodontal cysts, and some were just lateral radicular cysts or periapical cysts. And so that is not a term we use anymore. So OKCs, these are derived from remnants of dental lamina. So most of the things we'll talk about today are odontogenic lesions. In my principles of interpretation, I talk about how to distinguish between odontogenic or non-odontogenic, and things that occur in the odontogenic region. You should probably think odontogenic just because of the prevalence of odontogenic type of lesions. There are so many different odontogenic lesions that are more common, I would say, overall than your non-odontogenic counterparts. But if something is below the canal, you're not even going to put an OKC, right? This isn't odontogenic. It comes from odontogenic tissues. If something arises from within the sinus and it's not coming from within the bone in the maxilla, it's not going to be odontogenic. But if it's from anywhere within the maxilla that comes from within the bone around the teeth, or same thing with the mandible above the canal, it could be one of these odontogenic lesions. And so derived from these remnants of the dental lamina, these odontogenic tissues, and it just undergoes a cystic degeneration. I mentioned how this has gone back and forth between being classified as a cyst or a tumor. Radiographically, it has a lot of qualities of a cyst. It looks like it could be a sac of fluid, but it also has an inherent growth potential inside the lining. And so it does have tumoral and cystic type features. All right. The age isn't that descriptive for these, typically somewhat young compared to most cysts and tumors, second and third decades, but it does vary pretty greatly. The gender varies as well, maybe a slight male predominance. And these I think of as occurring anywhere around the mouth. Most things, as I said, they occur more commonly in the posterior mandible, but these can occur really anywhere. And this next picture is going to show you, yeah, posterior mandible, about half of them there. But they can occur in the posterior maxilla, even the anterior maxilla, or the anterior or premolar region of the mandible. One really unique thing about OKCs, and this is going to help you with your boards, if you know that the expansion pattern of these grow mesial distally with relatively little buccal lingual, or I would say superior inferior expansion. So what we mean by that is they grow along the bone. These next images I think will help with that. I kind of think of it as banana shape. See how it looks like a banana growing along the bone? It's not so expanding wide, so not buccal lingually or superior inferiorly, but mesiodistally. It grows along the length of bone. That expansion pattern is really typical of an OKC. So if you see that 9 times out of 10, that's going to be an OKC. Ameloblastoma, which we'll always have on the same differential with OKC, tends to grow a little more wider, more round, tends to expand more. And so that's what I mean by that expansion pattern, which is really descriptive of OKC. You see this one does resorb some of the roots of the teeth. Always pay attention to your effect on other structures. It is a nice straight across resorption, more of a benign type of resorption. In this case, it doesn't correlate perfectly with the borders of the lesion, but that pattern of resorption is more of a benign pattern. You also see the well-defined corticated borders. You see little septae inside. So OKC is one of those lesions that can be multilocular. It can leave septations, leave little locules inside. So it'll also be included in the next differential, which is multilocular radiolucent lesions. And this one's more of a unilocular OKC. So when they start, they can appear unilocular, or they can stay more of a unilocular lesion or start to develop the multilocular appearance. This one is displacing the tooth downward. So we just covered dentigerous cyst. How does this one look different than your typical dentigerous cyst? What is it? Give you a second to think about that. Right here where my pointer is. It's the attachment of the border. It doesn't come right up to or just below the CEJ. The attachment looks like it's way down here on the roots of the teeth. And so when you see that, probably your dentigerous cyst is going to be lower on the differential, and you'll think more OKC, probably first on the differential, maybe an Ameloblastoma, and maybe third your dentigerous cyst that would just happen to expand further and not show that typical attachment at the CEJ. The one on the left here, image A, has kind of a scalloping border. So OKC is one of the two things I really think of with a scalloping border. We'll get to the other one coming up soon. You see that rolling scalloping border, especially as it's scalloping between the roots of teeth, which I believe we showed you on the previous slide, but I didn't really mention it. If it scallops, it kind of dips up and down between the roots of mandibular teeth. That's our scalloping appearance. Think OKC. The next one to think of is simple bone cyst. This one does have a little bit of a multilocular appearance. Here's an axial slice showing very little buccal lingual expansion. So see how it's filling up the bone here? See how it's extending all the way through the ramus and even into the condyle, the condylar neck? But there's very little buccal lingual expansion. I said that was typical of an OKC. So this is through the mandible. This is an axial slice through the maxilla, so we're a little higher up here. So up here, further up in the ramus, there is a bit more expansion. So it can expand, but relative to the up and down expansion, the expansion following the bone, the buccal lingual expansion is pretty minimal. Another one with that great expansion pattern along the bone, maybe a little bit of inferior expansion. Maybe this tooth is being displaced a little bit, but it is kind of dipping down in between the roots of the teeth, that scalloping pattern. So both this longitudinal direction expansion and the scalloping pattern are typical of your OKC. Here in the axial slice, we really see it dipping in between the roots of the teeth, so that scalloping pattern. Very little buccal lingual expansion. Everything about this just shouts OKC. This is a fairly large lesion, expanding all the way through the mandibular body. And compared to how large it is through the mandibular body, there's relatively little buccal lingual expansion. More of the scalloping border, some internal septations. Axial slice here. This looks like a medical CT because you see the differentiation of the musculature so well. There's a little bit of expansion here of the mandibular ramus, some effacement of the lingual cortex here, as well as the anterior cortex. All right, so we said to distinguish from dentigerous cyst, we showed you that example where it looked like dentigerous cyst, but the attachment was well below the CEJ. Also that expansion pattern. Expansion pattern is a big differentiator from these other two things, which you'll frequently have on the differential with OKC. Ameloblastoma, greater propensity to expand. Sometimes the expansion pattern of dentigerous cyst is similar to OKC. So for this one, really look for your CEJ attachment. Lateral periodontal, I mentioned that globulomaxillary in the anterior maxilla. They found that that's not really its own distinct lesion, but that some of those tended to be lateral periodontal cysts. So if you see something in the anterior maxilla that's a well-defined unilocular radiolucency, could be OKC, could be lateral periodontal cyst. So have that on the differential. Myxoma, I'll mention those in the next lecture, the multilocular radiolucencies. And it's the pattern of the internal septation that really set that apart. We'll talk about simple bone cyst coming up pretty soon here. But management of these, yeah, you manage like a cyst, but these tend to recur more. And so it may require resecting a little bit more than you would for just your typical cyst. They treat these with various chemicals, various medicines to make sure they don't recur, because these do have a high recurrence rate if not treated properly. And so if someone has an OKC, they do need thorough radiographic follow-up even after the surgical excision because of that high recurrence rate. Hopefully you caught on to this. What is the typical expansion pattern of an OKC that really sets it apart, distinguishes it from other lesions? It expands along the bone. I said more commonly in the posterior mandible, but it can be in the maxilla. Instead of that wide expansion, that buccolingual expansion or superior inferior when we're talking about the mandibular body, it expands along the bone. Think of that banana-shaped expansion. That's your typical OKC. All right, getting to Ameloblastoma, or as they like to say in Night of the Roxbury, Amelioblastoma. If you haven't seen that, you have no idea what I'm talking about. But for some reason, I always think about that when I hear Amelioblastoma. So there is a Unicystic variant of Ameloblastoma. For those that may have had experience in Ameloblastoma, you may wonder why this is on the Unicystic lecture. It's because of this. Because there is a variety of Ameloblastoma that is just well-defined and looks Unicystic. Typically, these occur in younger patient population than your more common soap bubble Ameloblastoma. So this is an example of one. See the very round expansion? Just mentioned with OKC, how it has that more elongated banana-shaped expansion, and this is more round. So it tends to expand wide, can expand more buccolingually, but still well-defined corticated borders. How old is this patient? Second molars haven't even erupted yet. Maybe they're 11 or 12. And so younger patients than most lesions. They can be very locally aggressive. Yeah, for the Unicystic, average is pretty young age. Even in children, these can occur. We said these tend to expand. They tend to expand round and large, and so these can grow very large. You may have seen images of odontogenic tumors on social media. It tends to be more in third world countries because they let them grow very large. And we see someone with a very large tumor on their face that has not been treated. A lot of times that's an Ameloblastoma. This is one where it's really eroded the anterior border of the ramus. This was the image we just showed you on the last slide. More common than other lesions, more common in younger patients than your average lesion, and more common in younger patients compared to your multilocular one. Most of them in the posterior mandible. This one's starting to get a little bit of that multilocular appearance. Still a relatively young patient, third molar still not developed. You see some resorption, very benign pattern of root resorption here. Well-defined, corticated borders, but more expansile. I would say if you compare to those OKCs, this looks a bit more expansile. Could this one be a dentigerous cyst? Sure. Looks like it attaches at the CEJ of this impacted tooth. Or this could just be an Ameloblastoma, an OKC, that has displaced this tooth inferiorly. And in this case, with the expansion pattern of it, maybe Ameloblastoma fits before those other two. And Ameloblastoma does have a high propensity to resorb teeth like this. A very straight across, benign type of resorption of roots. Resorption right there. That one looks like it remains intact, but well-defined corticated borders. Nothing about this looks concerning for malignancy. It looks like a benign tumor. Benign tumors tend to resorb even more than cysts do. All right, let's get to simple bone cyst, also called traumatic bone cyst. Those are the two really that I'll stick with, the two synonyms for this lesion. They used to call it traumatic bone cyst, assuming that it arose from having previous trauma to the area, but they've since gone away from that and more call it just a simple bone cyst. And this is not a true cyst. This is just a bone cavity. It's either empty or may contain fluid. Some surgeons say they open it up and it's filled with blood, but it doesn't really have a lot that's distinct about it. You don't have an epithelial lining that you can get out and look under a microscope. When they open these up, they cut into them, and it just tends to be an open cavity within the bone. They should just call it a bone cavity. In fact, they do. Progressive bone cavity, unicameral bone cyst, so a lot of different names for it that I don't typically use. These do occur in younger patients. Typically late teens is kind of common to young 20s. I mentioned how it can occur in conjunction with cemento-osseous dysplasia, particularly the florid cemento-osseous dysplasia. You see a lot of those radiolucencies around your cemento-osseous dysplasia. Those tend to be simple bone cysts. Typically asymptomatic, really rare to have it expand. I said this isn't really a true cyst, isn't really a true tumor. It's just kind of an expanding bone cavity within the bone. Usually incidental, but they can grow to a somewhat large size. They're just not going to expand very much. Most common in the mandible, anywhere really in the mandible. More common in the posterior, but it seems like we see a lot of these in the anterior. Well-defined cortex, but if you compare this to an OKC, which I said those are the two that have the scalloping borders, or OKC and simple bone cyst. So the one thing that really distinguishes those two is the border of the lesion. You see how it's corticated, but it doesn't have that very, very thick, distinct cortex, just a thin little line around it. And then particularly around the floor of it, maybe it doesn't really show it in this case, but the floor of it doesn't have much of a very distinguished cortex. The roof of it will probably have a more established cortex. So probably we'll see some examples of that as well. As I mentioned, scalloping between the roots of teeth is great. This one doesn't really show it because it just barely reaches the apices of these mandibular incisors. It's going to be radiolucent. Rarely will you see, well, sometimes it has the appearance of a multilocular thing where it kind of causes a scalloping on the buccal and lingual cortices, and that makes it look like it has a multilocular appearance. Here's another distinguishing feature of simple bone cysts. The lamina dura intact. We mentioned scalping around the roots. This is just, remember, an open bone cavity or an empty bone cavity, and as it's growing in between roots of the teeth, it doesn't really resorb the lamina dura, so it grows up in between the roots of the teeth and leaves that lamina dura line intact. Very strong indicator of a simple bone cyst. Mentioned minimal expansion with them. Here's panoramic. This is one that kind of has that multilocular appearance. I imagine is more kind of scalloping within the borders around it, but it can have a multilocular appearance. If you see really close, and here let's look at the periapical image. Do you notice the lamina dura? Lamina dura remaining intact all around the lesion. So that appearance right there strongly shouts, in my mind, this is a simple bone cyst. Scalloping, lamina dura. We said OKC can scallop. It seems like OKC tends to erode the lamina dura more than a simple bone cyst, but it could have a similar appearance to this. And so you look at the borders of it. Yeah, are there very thick cortical borders around it? Not really. For an OKC, there probably would be a thicker, more established cortex around it. Here's an example where you do see somewhat thick cortex on the roof of it, on the superior border, but not so much around the outside. It can even have the appearance of a more of a blended border in some areas, as you see there. So very, very thin, wispy borders, and in some cases it can appear blended, but a lot of it is telling you that it's a benign lesion because it has those corticated borders, because it's scalloping, because it's leaving lamina dura intact. Here's an occlusal radiograph showing that this lesion, compared to its relative size, has very little buccal lingual expansion. So in that regard, it's similar to OKC. We said these don't tend to expand much. This one really has a multilocular appearance, kind of scalloping through the inferior border here, also scalloping around the roots. This one looks like it's leaving little trabeculae intact or septation intact here between different loculations. This one has a kind of a cross-sectional view. This looks like an anterior tooth. And it does show a little bit of scalloping into the lingual cortex, into the buccal cortex, but not much expansion. Just an occlusal view. Looks like the same one here, showing that scalloping border into the into the buccal cortex. This is a fairly large one in the mandibular body, extending back to the angle. In the axial slice of the CT, you can see there's very little buccolingual expansion again. You see a little bit of that sign of the lamina dura intact. Harder to differentiate that in a panoramic radiograph than it is in a periapical where you have better resolution. You can see that lamina dura better. All right, so we talked about differentiating from an OKC. Look at those borders. Simple bone cyst has more definite or more delicate borders for a simple bone cyst. The OKC is the one that has more definite described corticated borders, distinct corticated borders. More likely to cause displacement and root resorption in tooth. Simple bone cyst, really you're not going to see that unless just secondarily you happen to have resorption of the tooth. OKCs also in an older age group. Remember simple bone cyst, what was that? That was in your teens to 20s on average. OKC can occur in patients that young, and it is younger than most other lesions, but maybe a little bit older on average than your simple bone cyst. Sometimes simple bone cysts, we said, can have an ill-defined border, a blended border, so you might mistake with malignancy. But look for areas where it shows at least some sign of a corticated border. Look for that lamina dura to remain intact as a sign of a simple bone cyst rather than a malignancy. So these, the management, you're not going to be able to really excise these like you do with a cyst. You kind of nucleate it because there's no real cystic lining to it. There's no soft tissue capsule. It's just an empty bone cavity. So the surgeon goes in, they open it up, and they kind of scrape out the inside of the bone cavity. They curettage the lining. That initiates bleeding and initiates healing. I've seen an example of these where they spontaneously heal. So it's just, not really a true distinct pathology, more of just a growing empty bone cavity. Rare that they'll reoccur if this healing has been instigated. And so they take these out, they take whatever scrapings they can and send that to a pathologist, and the histopathology report comes back as just normal tissue. Because there really isn't, as I said, a lining to these. What's the key way, radiographically, to distinguish simple bone cyst from OKC? Because I said there are a lot of similarities. They expand similarly, but it's the border, right? The border of a simple bone cyst has that thin, wispy border. Superior border might have a more distinct cortex, but around the outside of it and the inferior border, not really a very distinct cortex. Here's another thought question for you. I keep saying the inferior border. What about the maxilla? Why do I keep saying inferior? And I'm imagining in my head the mandible, because these mostly occur in the mandible. Very rare to have a simple bone cyst in the maxilla. I don't think I've seen an example of that. All right, this is a good one to know just because it is so common. Going to be somewhat similar to a simple bone cyst, but as opposed to a growing empty cavity, this is not something that tends to grow. This is just a marrow space, just osteoporotic bone marrow. We see these in a lot of cases of extracted teeth. Maybe the bone just doesn't heal in there. The trabeculation never gets really established, and we'll call that a focal osteoporotic bone marrow defect. And if you were to send this off to histopathology, you would just see normal hematopoietic or fatty marrow. So a couple different theories on how they arise. Can be in men or women, but kind of the classical presentation of these is a middle-aged woman is when you see it occur. Especially when they have osteoporosis, they may start developing these osteoporotic marrow defects. See how the lining can appear really similar to a simple bone cyst, but it does have more of an established cortical border all the way around it. Or you might describe this as just being surrounded by regular trabeculation. So they're typically not perfectly round like a cyst, a little more irregular in shape just because of that, because it's just marrow space, and the surrounding trabecular pattern tends to have somewhat of a jagged or irregular pattern, as we see in these cases. All right, this is a little bit more rare lesion than some of the ones we've been talking about. As I said, most of them tend to occur in the posterior mandible more commonly. But Ameloblastic fibroma, a few synonyms for this. Most of these are pretty old, outdated synonyms. This is one of the lesions that I consider a pediatric lesion. You can have it in a really young patient, usually not over the age of 20. So around the age of tooth formation, on average, maybe the higher end of that, 15. Everything here is just typical of your cyst or benign tumor. Can cause pain, can be left with a missing tooth. And in a lot of cases, it'll be associated with a crown of an unerupted tooth. If you show a pedodontist a child's radiograph and they have a well-defined unilocular lesion around the crown of an unerupted tooth, the other thing they might say other than dentigerous cyst is this. So think of that, especially in a child when you have unerupted tooth, something around the crown, an ameloblastic fibroma. So as with all these other things we've been talking about, this is a well-defined corticated lesion. Normally going to be radiolucent. This is a case where it somewhat is starting to look multilocular. This one looks more like it's not coming from the follicle, right? Looks a little distinct from your typical follicular cyst. More like it's developing or extending here distal to the crown of that impacted tooth. But then you also have, well, you have something going on all around it, but the follicle remains intact. And you have this lesion that's extending around it. Some other examples, somewhat small one, you have this impacted third molar, something starting to expand up the ramus. It does here have a well-defined corticated border. Maybe up here it's a little less defined. But when you see some of it, as I said, that is a definitive corticated border, start thinking more of these benign type things. Again, anytime you have an impacted tooth, you have this cyst-like or well-defined radiolucent lesion with it, especially in younger patients. Ameloblastoma can be on your differential. This just looks like our gubernaculum dentis, but I guess they found that this was expanding and found that it was a ameloblastic fibroma. Here's an interesting one. If it starts to calcify, we'll cover this in one of the upcoming lectures with calcifications, but I would term it an ameloblastic fibroodontoma. I just think of that as a calcifying counterpart to your ameloblastic fibroma. All right, first and second molars. This I would just describe as a hyperplastic dental follicle, but you could suspect maybe a dentigerous cyst, or the other thing on your differential is going to be ameloblastic fibroma. This one happens to look, I probably wouldn't think ameloblastic fibroma first thing in this case. It looks like an adult patient. I don't see an impacted tooth. I would be thinking your OKC. Most likely the way this expands. Maybe an ameloblastoma. It does start to look like it's forming septation, so somewhat multilocular. Kind of moderate buccolingual expansion compared to the size of it. So yeah, I would probably have OKC first with the differential, and then you're always going to think ameloblastoma next. So this is kind of a rare presentation for ameloblastic fibroma. All right, might be difficult to distinguish from a dentigerous cyst or hyperplastic follicle, as we saw in some of those cases. Older age for most of these other lesions. Ameloblastoma, we'll get to our typical ameloblastoma and how that's different with the real soap bubble loculations. We'll talk about some of these other lesions also with our multilocular lecture that's coming up. Management, as with most things, enucleate, curettage. These do have a low recurrence rate, so not as worrisome as the OKC. All right, time to test your metal. Give you a chance to look at these and come up with your best guess to what you think it might be. Can you describe the lesion? Think of your lesion acronym, location. Well, you can describe the location. It's inferior to the first and second molar in the mandibular body. Looks like it may be associated with this impacted third molar. The external or the periphery, does it look well defined, corticated? Yeah, I see these corticated borders. It's expansile. I'm already getting to effect on other structures. So S is our shape and size. It's rounded. You can kind of describe it as occupying the mandibular body from the angle to inferior to this premolar, the second premolar. But you might want to do measurements and describe it more fully with your size. It's expanding inferiorly. Is there a little bit of scalloping? Is there a little bit of root resorption? Now we're on, well, I didn't mention the internal structure. It's kind of obviously, I think, radiolucent, completely radiolucent. So I don't see any type of other internal pattern to describe. So it's radiolucent. Effect on other structures though, resorbing the roots of these teeth, expanding, which we already mentioned. Displacement of the canal? Not really. It follows the same path there. Is it displacing this tooth? Is it causing this tooth to remain impacted? Possibly. Is it associated with the crown? So we said with, you may be thinking, okay, is this dentigerous cyst? Does it attach at the CEJ? Really, it attaches lower. I don't really see the attachment on the distal surface. So you might have OKC on the top of the differential. And I would agree with that. This one does happen to be a dentigerous cyst. So when it is associated with an impacted tooth, even if you have OKC, because you see that attachment further down on the root than at the CEJ, remember to have dentigerous cyst. In fact, one of my acronyms to remember is DOA. Dentigerous cyst, OKC, Ameloblastoma, when you see these unilocular radiolucent lesions in the jaws. So if it's associated with an impacted tooth, DC, dentigerous, should be on your differential. But I would probably not even have it first in that case. All right, this one doesn't have much distinct about it if you're looking at it, right? It's just a round, well-defined, corticated lesion. But where is it? And think, what's a possible history in this case? It's in the region of a third molar. So they could have had a third molar there. Could they have had a third molar with that had a periapical lesion that was extracted, and then this would be a residual cyst? The history reveals, maybe in this case, that they never had a third molar there. If they did, they didn't have any cystic lesion around it, and this developed within the past several years. This is a 23-year-old male. And so if we ruled out residual cyst because the third molar was extracted with no remaining cyst there, what else could it be? Well, back to our DOA acronym, not dentigerous cyst because there's not an impacted tooth there. But it could be an OKC, it could be a Unicystic Ameloblastoma. This patient being 23, maybe not too old for a Unicystic Ameloblastoma, but just the right age for an OKC. It's not large enough to really tell the expansion pattern to help us differentiate those two, but this one is an OKC. So again, just our DOA acronym helps us. Okay, so there's something I mentioned a little bit, but I didn't really focus on lateral periodontal cyst in this lecture. I talk about that in my location-specific lecture because those have a very specific location. This one happens to be that location, which is right on the lateral surface of a tooth, particularly mandibular premolars. And so you might see this and see it's somewhat well defined. I don't see corticated, so I wouldn't describe this as corticated. But it doesn't look like a blending or irregular border like a malignancy would be. This looks more well defined, even if you have to kind of imagine more of a fat crayon to draw a distinct line around it. I would stick with well defined. You see these rounded borders of it. And so you might have lateral periodontal cyst, top of your differential. It could be a lateral radicular cyst. But when things are small like this, it could be anything. So it could be our DOA acronym. I've seen Ameloblastomas look like this. So everything starts small, starts round, well-defined. Could be either of those. This one turned out to be an OKC. So remember me mentioning globulomaxillary cyst? Typically the anterior maxilla, but you could have the same differential on the anterior mandible. This is just distal to the canine, but it's that same location. So lateral periodontal, OKC, or lateral radicular, and this one is an OKC. But nothing too distinguishing about that that's telling you that that one was an OKC. This one should be just our DOA acronym. Is it a dentigerous cyst? Maybe you'll have that first on the differential. You see the well-defined corticated borders attaching at the CEJ. No reason that this shouldn't be a dentigerous cyst, but what else would you have on the differential? Always have more than one thing on your differential. So you would think OKC, you would think Ameloblastoma. Is it a young patient? Maybe a little older than your typical Unicystic Ameloblastoma. This one turned out to be an OOC, which I had in this lecture, but I removed it. That's a pretty rare lesion. They used to be considered a variant of OKC, and radiographically really difficult to distinguish the two. Really, that's a histopathologic differentiation, whether this would be OKC or OOC, which stands for orthokeratinized odontogenic cyst. As I said, really similar to OKC, used to be considered a variant, but I don't get too much into the details of an OOC, because I think if you say OKC and it ends up being an OOC, radiographically, you're pretty much right on. All right, what about this one? Where's the problem? Should the tuberosity be that blue? It's kind of expansile. What did we call this? As a radiologist, I'm not going to show you many clinical photos, but this was the soft tissue counterpart of our dentigerous cyst, an erupting tooth we expect to see here. Maybe this patient is around 12 years old. And so this is our eruption cyst. Blue because it's filled with fluid, a lot of times filled with blood. These may not require treatment or a simple little incision to release the fluid from that can help the tooth erupt. All right, so I'll show you this one. Describe its effect on other structures. Hopefully you recognize well-defined. I would even go as far as saying corticated because parts of it are, but it's very, very strictly well-defined. And it's resorbing the roots of these teeth in a straight manner, following the curve of the lesion. Not much resorbed there, but these are the roots. So what type of things are you thinking? You see scalloping, you think two things, hopefully. Simple bone cyst, OKC. Which of those is more likely out of this? This to me is a little more pronounced than your simple bone cyst. And especially the resorption of the roots of the teeth. You're not going to think likely to be simple bone cyst. All right, what about this one? Well-defined corticated borders, somewhat scalloping here, displacing the inferior alveolar canal. And a natural placement of inferior alveolar canal is never going to go this far inferiorly, so there's displacement of that. So based on the scalloping borders, the expansion pattern will help you out by showing you the axial slice here, and there's relatively little buccolingual expansion. Hopefully you're thinking OKC. Or you think maybe it could be a dentigerous cyst, right? I said those things can be difficult to distinguish. Attachment of the CEJ, attachment a little bit lower than the CEJ here. And as I said, I'm not going to delve too much into histopathology at this point. But an OKC has a lot more of a distinct epithelial lining, a palisading basal layer. And this is just a thin epithelial lining, nothing very distinct about it. Maybe a little bit of inflammation. But this is just a dentigerous cyst. So maybe I would have had, based on the radiographic appearance, first I would have thought OKC. But you have to notice, attachment around the crown of this tooth, and definitely have dentigerous cyst on your differential. This one's scalloping, a little bit of root resorption. So scalloping, I said think simple bone cyst, think OKC. That little bit of root resorption, you're thinking more likely which one? Hopefully you're saying OKC. If you see an axial slice, if you know there's very little buccolingual expansion. But even looking at the panoramic, and there's not too much expansion outside of the borders of the jaw, that expansion pattern is more of an OKC than it is other things. We just saw on that last slide, dentigerous cyst can do that. I don't suspect dentigerous cyst in this case because there's no impacted tooth. So everything about this is OKC. All right, I hope that was helpful. Do refer to your chapters in the White and Farrow book. Look back at your pathology book and review these different lesions that we talked about today. Each of these books has a section on any of those lesions that you can read and give you a lot more insights than I did in this brief lecture. So we'll see you on the next one. Take care.